Hi, my name's Shaz. I'm a consultant virologist a little way down the road at Manchester Foundation Trust, and I'm going to talk about hospital demand modelling. So I became a consultant on the 6th of January 2020, and then my first COVID meeting was about a week after that. So we essentially went straight in, and luckily Thomas and I were already friends, and I think that every virologist should have a mathematical modeler as a friend. So what that meant was that when we were sort of thinking about the challenges that we might face at MFT, we're sort of one of the largest trusts in the country, a lot of beds, numerous sites, and thinking about essentially how you handle the unknown. We knew that we would need to have a bit of the hospital that was doing COVID work and a bit of the hospital that was doing, normal work, cancer surgery, emergency, admissions for other reasons, and then maybe a bit of the hospital where we didn't really know what was going on. And we would need to be able to move between those states for different wards at different times. We didn't know how many beds we were going to need. We didn't know how many ICU beds we were going to need, how much oxygen. So suddenly oxygen became a big issue about being able to predict your need for it and how you get more ventilators, and that's a whole other topic. And also how long people were going to need to be in hospital and need to be on intensive care. How do we carry on doing elective surgery? And when we were discussing these things in the trust, it occurred to me that we may be able to use mathematical modelling to help us. And so I spoke to Thomas, and he was very kind in offering to help out. And I mentioned it to our medical director at the time, Jane Edelson, and she immediately got it and jumped on the idea. And I think Thomas was sort of sat in her office 2 days later and had an honorary contract within a small number of days thereafter. And that's not to say that it was plain sailing from then on. Our data at the time was not tidy. There were lots of other challenges. But the thing that we needed to work with was that I think everybody remembers this graph from the pandemic, and this idea that there's a sort of a fixed health system capacity. In reality, it's not fixed because it depends on what you're trying to do at the time. If you're, you can stop doing cancer surgeries and admit more people with COVID, or you can try and balance those things out. So being able to move between different states was really critical for us. And so knowing where we were going to be in a week's time, in 2 weeks' time, was really useful. And actually, just having something to work on, a sort of a best guess, was really useful. Lorenzo mentioned earlier on that the NHS does its own models, and MFT also has a go at doing its own models, but it's not in the same way as a mathematical modeler would do a model. We sort of have data analysts sort of running models. So actually having a more expert opinion on how things might shape up in the next few weeks was really useful to us. And we've already heard about epi beds. So this was fantastic for us because we used it to model demand within the NHS. And I'm just going to move on for the sake of time. But for MFT, we had our own model that was written by the team here, and Bindu and Chris sort of ran it for the first 2 years, I think. I think it ran for about 2 years in the end. And this was a really useful model that allowed us to look at real-time bed occupancy and demand. And it's been cited many times, and was really only possible because we were able to make those early links between the university and the trust. And actually, what that allowed was for the Greater Manchester Healthcare Network to access modelling as well, because we were doing this for it was called GM Gold at the time, and that was sort of the medical directors of all of the trusts coming together, and everybody was getting a report for their hospital bed demand. And so the model is a multi-state model. So I'm not going to lecture you about mathematics. I don't know anything about mathematics really, except to say that it's a framework that you can use to analyse how an individual might move through their hospital journey. So rather than just being sort of admitted or discharged, you can have different states such as admitted to a ward, admitted to intensive care, requiring high flow oxygen, requiring ventilation. All of these are different states, and you can move between the different states at a rate that either you can study and then input into your model, or you can theorize from other disease conditions. And I think this is just explaining those transitions pictorially. And so there is a fixed risk of moving to any of those situations, any of those states, and whichever state you move to, you can then move to the following states at a fixed risk as well. And so we can simulate hospital occupancy for each of the different settings. So we were providing estimates for acute ward occupancy and ICU occupancy, and those were really useful in terms of being able to plan how much critical care you needed. So, again, this wasn't something that was fixed. We were expanding and contracting the number of intensive care beds. So we were, theatres, for example, have recovery areas that can also be used as critical care beds. But that means that you can't do your elective surgery then because you don't have a recovery area. So actually having this ability to predict how many critical care beds you're going to need was really useful and important because it allows you to carry on your normal activity. And so our experience, I think, was tremendously positive. As I said, Greater Manchester was getting a weekly bed demand report, and this was being discussed on a weekly basis at a meeting of all of the medical directors that was called GM Gold, and that helped redistribute pressure across the region. Some of the medical directors were talking about, who had critical care beds, where could we move patients to, where, which sites would be able to carry on doing elective surgery, could we move some of the elective cancer surgeries from one site to another site to make sure that they get done. And I don't think that would have been possible in this way without the help of this modelling. I think if Jane were stood here, so Jane was the chair of Greater Manchester Gold for, I think, pretty much the whole of the pandemic, I think she would tell you how much she valued having this insight. And it also allowed us to understand the demands in the context of where we were in the pandemic. Clearly everybody gets, information from the media, but actually what is going on in Greater Manchester at the time, what's going on in our trust. And this graph shows you how we went from Delta to Omicron across the city. And so actually there was a lot of interest from the medical directors to understand, well, actually how much of what we're seeing right now is because of a different variant, how much is because of, some other practice that's going on at the moment. So this was really useful and very much valued. So currently, unfortunately, things have tightened up a lot in terms of data sharing, and we've had some challenges over the past couple of years of getting back into being able to provide useful models, but we're getting there. The data is still valued. I think the reports that we're producing, so Thomas and I produce a weekly report over the winter on acute respiratory infection for Manchester Foundation Trust, and I know that our chief exec looks at it on a weekly basis and asks me to provide sort of further analyses on things. So I think it's still valued. What we're struggling with now, I think, is how do we work in a non-pandemic situation? Thomas had his honorary contract at the beginning of the pandemic within days. When it came to renewing it, it took about 9 months. Medical directors get busy with other things, and so these things slip. But I think we need to try and keep this at the forefront of what we do, because actually the models and the reports that we start producing during non-pandemic periods can then be very quickly adapted, when the next pandemic hits. If we can make sure that we understand, like now we have a new electronic patient record, or we've had it since September 22 at Manchester Foundation Trust. We have a phenomenal amount of data there. And so if we could start understanding that data, then when the next pandemic comes, we'll be able to say, hopefully, more insightful things, and being able to link that data with primary care data, such as vaccination rates, and other comorbidities that maybe are not in the hospital system, would allow us to have a lot of confidence in the data that we're using. The sort of the chest data, with all of the kind of the national data sets are not very detailed. There's not a lot of granularity there. What we can do locally is we can have granular data sets that will allow us to say really useful things about who's the most at risk, who's doing worse in hospital, where are treatments more effective. I think all of that really comes from having the granularity of data that you only get by working closely with hospital trusts. And so that's what we're trying to do, with some mixed success at the moment, but we'll persevere. So this is just, so 88% of our respondents found the report that we produced very useful or extremely useful. And it's interesting, I think, now to, it's primarily flu that is of interest to our medical directors at the moment, but we continue to look at COVID, and we also look at RSV. There's a vaccine that's been introduced over the last couple of years, and so looking at how that affects admissions, I think is really interesting. So this is actually our report for last week. So we've seen this huge increase in flu over the past week. And so in future, we'd like to be able to model bed demand by patient location again. So we're not there at the moment. The data is messy. We need time, we need money to do those things. We are making a log linear extrapolation at the moment for admissions, but this is very rough, and we're looking to develop a full Bayesian expert-informed prediction model. And we'd like to link with other trusts as well, because what we're developing, if we develop a model for MFT, then it'd also be useful to know whether that is useful to other trusts, whether it works for other trusts. Because again, whatever we're doing for MFT, ideally in the next pandemic, we would be able to roll it out for other hospitals as well.